Great. Well, thank you very much. Thanks to the conference organizers for inviting me to speak. I got to thank two people of this sort of group first before I start. First is Mariam Alavi, who's one of my PhD students who actually did all this work. So credit to her, and also to Mark Tyndall, who's at the University of Ottawa, who's the PI of the CHASE study, which I'll talk about. So we're going to be discussing low uptake of treatment in a large community-based cohort of inner-city residents in Vancouver. So if we consider the HCV epidemic, and a number of people have sort of already discussed this today, but people who inject drugs are really at the core of the epidemic. So if we look at the number of new infections each year, 80% of new infections occur among people who inject drugs. And if we look at existing cases of HCV, about 60% of existing infections actually occur among current and former people who inject drugs. Now, we know from a recent systematic review, there's now been sort of a number of studies which have looked at Hep C treatment among people who inject drugs. And when you look at sort of the median SVR across these studies, the overall SVR is around 56%. And so when you compare this to large clinical trials of PEG and ribavirin, these are very comparable. However, HCV treatment uptake among people who inject drugs is actually quite low. So there's a number of different studies that have been done previously, actually, by our group in Vancouver, some work done in Baltimore, and then also some work in Australia. And pretty much across the board, treatment uptake looks like about 1% to 2% are actually treated per year. So, given what we've discussed today, this certainly needs to increase. This is some data from the CHASE cohort, which I'll be talking about, but it's a cohort of inner-city residents in Vancouver, and it's looking at mortality. And what you can see here is that this is the rate. Sorry, my pointer's not very bright, but anyways, on the y-axis is rate, and by age. And what you can see is that in red is the liver-related mortality, with sort of an increasing mortality as you get older, which as you get above 50 years of age starts to compete with drug-related and HIV-related deaths. So what's happening is that people that were infected in the 1970s and 80s are becoming older, and we're seeing this increasing tide of liver-related morbidity and mortality occurring in this population. So the aims of this particular study is in a large cohort of inner-city residents in Vancouver, Canada. First was to assess trends in HCV treatment uptake, and two, to examine factors associated with HCV treatment uptake. So I'll explain a little bit more about the Community Health and Safety Evaluation Study. So study participants, to be included, you had to live or utilize health services in the downtown east side of Vancouver, and participants were recruited from community organizations, word of mouth, and door-to-door canvassing of a random sample of single-room occupancy at hotels in the area. So with respect to follow-up, so it was really unique in that what we did is people provided consent to link to health service databases. So in a way, so it's a one-time survey, but it allows you to sort of look back retrospectively and then move prospectively into the future, almost sort of a virtual cohort, if you will. And so we performed a number of different linkages. Linkage was performed based on date of birth, sex, and personal health number. So it was linked to the BC Centre for Disease Control and UBC Virology. And as was already mentioned by Andrea, they perform greater than 95% of all the testing in the province of British Columbia. And so we linked HIV and hepatitis C testing. And we also linked to the BC Vital Statistics database, which includes information on mortality, both cause and date, and also the BC PharmaCare database, which includes from 1998 to 2010 all prescriptions for HCV treatment from publicly funded sources. So as I mentioned, the endpoint for this particular study was HCV treatment uptake, and so this was the linkage to prescriptions for ribavirin with either interferon or PEG interferon. So up to the time of when the study ended, no patients had actually initiated on telaprevir or boceprevir. With respect to the statistical analysis, so we looked at factors associated with HCV treatment uptake, and this was done using logistic regression analysis. So just to give you a flavor of the participant disposition of the CHASE cohort, there was just under 3,000 individuals recruited into the cohort, and of these, 83% had HCV antibody testing available, so just over 2,400 people. Of those, not surprisingly, 64% were HCV antibody positive. And what we did is we had information on HCV RNA testing. So we removed anybody that had spontaneous clearance, which was 18%. And so of those, 1,257 were eligible for HCV treatment. Now, over the period 1998 to 2010, in this cohort, only 77 individuals were treated, so 6% over almost, over a decade. Just to give you an idea of some of the participant characteristics in this cohort, mean age, 42 years of age, 2/3 male, large proportion of Aboriginal ethnicity, almost 1/3, low proportions of stable housing. But interestingly, and probably as a result of the intense efforts of Vancouver Coastal Health, large proportions actually report having regular doctor or having usual access to healthcare. Just over 2/3 on methadone, 30% with HIV, and you can see that non-injecting plus injecting drug use just under 90%, with injecting drug use just under 60%. So we wanted to look at factors that were independently associated with HCV treatment uptake, and I'm only showing you the adjusted models. And what we observed was, and it was actually interesting seeing Marina Klein's presentation because it was very, very similar variables, but we found that, and so anything less than 1 is a decreased likelihood of receiving treatment. So people of Aboriginal ethnicity were about 4 times less likely to have received treatment. Individuals who had engaged in crack cocaine use, so we know that that's particularly marginalized group, were less likely, and methamphetamine injectors were less likely. Now this bordered on significance, but when we looked at the adjusted models, it was actually a better fit, including methamphetamine injectors in the model, so it stayed in. And there was a number of other factors that were not associated with treatment uptake, but as we all know, these factors are relatively intertwined. So this is just looking at HCV treatment uptake per year, and it's the rate of HCV treatment uptake. So you can kind of look at it as a percent per year. So it ranged from about 0.2% per year in 2003 to sort of just over 1.5% per year in 2009, which is still quite low. And if you look at cumulative HCV treatment uptake over time, so by the time 2009, we see just over sort of 5% that were treated for hepatitis C. So look, I think there's a number of strengths and limitations to this study. The strengths is the nature and the recruitment, and the Chase study team and Mark went through great lengths to recruit people by comprehensive peer and community-based outreach strategies based on census data. So it does provide a sort of relatively good picture as to what's going on in this neighborhood at that particular time. And then we had this ability to do this unique data linkage with various viral laboratories and sort of vital statistics in HCV treatment. So there are limitations. I totally take that. Look, there was the serological testing was not systematic. We were sort of we used what was available as per the prescribers and the testing they did. And also the questionnaire only covers demographic and self-reported data at the time of the questionnaire. So it's a limitation, but it's a pretty unique way to kind of study people over time. So in conclusion, HCV treatment uptake remains low in this population. There's been a modest increase in HCV treatment uptake between 2003 and 2009. And we found that Aboriginal ethnicity, crack cocaine use, and methamphetamine injecting were associated with lower HCV treatment uptake. Now, we've seen this a number of times throughout the day, and this is the HCV care cascade. And so in this particular cohort, 80% had actually received treatment. We don't know how many were actually assessed and monitored because we don't have that data, so it's somewhere in between 0 and 80. But we do know that 6% actually were engaged in treatment, and assuming an SVR of 50% during this time point, so 3% overall had virological cure. And it's not good enough. We do need to improve this, because this is where a large burden of infection and morbidity and mortality is concentrated. And so, look, I've borrowed this from Dave Thomas, and we've sort of worked on it a bit. But and as Lauren sort of pointed out, highly efficacious treatments don't help if they aren't given. And so we had an SVR of 40% in 1998, 55% in 2002, 70% in 2012, and we're shooting for 90% or above probably before 2018. Now, if you look at the number of people that weren't receiving treatment in 2012, there's still 95% of people that aren't receiving treatment. And so I think we need to do a better job at sort of looking at strategies to increase diagnosis, increase assessment, and then increase treatment outcomes across the HCV care cascade. So just in terms of acknowledgements, I'd like to obviously thank the CHASE study team, Dr. Mark Tyndall, who is the PI of this study, and particularly Maryam Alavi, who did the majority of the statistical analysis and put together this work. So thanks for your attention, and I'll take any questions.